Hello, and welcome to CLL Society's 8th webinar dedicated to COVID-19. We have two great speakers today who will provide brief presentations to catch us up on the ever-evolving information about COVID-19. We are also going to hear about what the most current information means specifically for the CLL and SLL community. The majority of today's event has been reserved to allow time to answer your questions. I am Robin Brumble, a registered nurse, as well as Director of Scientific Affairs and Research for CLL Society. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL community because we believe smart patients get smart care. Throughout this pandemic, we have been continually reminded that CLL patients and caregivers need to continue to be extra vigilant in their daily lives to avoid COVID-19 and other infections to the best of their abilities. As a reminder, if you missed any of our past COVID-19 virtual community meetings, you can still find them on our website under both the COVID-19 updates page and the on-demand education page. We would like to thank Regeneron, Pharmacyclics, and Janssen for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, who is the Executive Vice President and Chief Medical Officer of CLL Society.
Thank you, Robin, for setting things up and for that introduction. I'm glad to be here, and I'm excited about this presentation. We have a great faculty. We're joined by Dr. Joshua Hill, assistant professor, and his areas of expertise are in vaccine and infectious disease and clinical research at the Fred Hutch in Seattle, Washington, which deals with a lot of immunocompromised patients. And Dr. Samir Parikh, an assistant professor of medicine, hematology consultant, the Division of Hematology at the Mayo Clinic in Rochester, Minnesota. And Dr. Parikh's area of expertise and research is in CLL. He's also a member of the CLL Society's Medical Advisory Board. I'm also going to briefly discuss one of our major resources and remind you of that, our COVID-19 action plan. And I'm going to talk about the Test to Treat initiative that was just launched today at 9 a.m. Pacific time that President Biden mentioned in his State of the Union address. Before we begin, we have some poll questions that I'm going to go over. 4 poll questions, and I guess we can start with the first one here. So make sure you see all 4. You're probably going to have to scroll down, but I'll read them and you can just do them in at your own time. Question 1 is, have you been able to obtain Evusheld, the only authorized long-acting monoclonal antibody that can prevent COVID-19 infections prior to exposure, what we call pre-exposure prophylaxis? Simple yes or no on that one. Number 2 is related. Have you tried to obtain Evusheld but have not been successful in finding a dose? Yes, I've tried but not been successful. No, I have not tried to obtain Evusheld. And 3, not applicable. I have obtained Evusheld. Question 3, if or when your vaccinations are up to date and you've obtained Evusheld, will your behavior change in any way, such as being more willing to visit with friends indoors or travel or eat at a restaurant or attend indoor events? So will you feel safer to do these kinds of things? Do you strongly agree with that? Agree? Feel neutral, disagree, or strongly disagree? And at least for me on my computer, I've got to scroll down to see question number 4, and that deals with the emotional cost of the pandemic. I have suffered from increased anxiety and or depression over the past year due to the COVID-19 pandemic. Do you strongly agree with that statement? Agree? Are you neutral, disagree, or strongly disagree? And here's our answers here. So interesting here, and this is very similar to even when we looked at this at our last poll, that 40% of you have been able to obtain Evusheld, but 60% not. And we'll talk a little about the distribution issues later. And we can see that less than 20% have tried and not been successful, and almost 40% have not tried, and almost an identical number were able to obtain it. So very interesting there. And this is also interesting about how our lifestyles will change. So if we look at almost half of you would agree, and if we add in strongly agree, more than half would strongly agree that their lifestyle would pick up. They'd feel a little safer moving out into the world with Evusheld aboard and with their vaccines up to date. And again, this is, I think, similar to what we've seen in other communities. That close to 3/4 of our community is affected by the emotional strain of this, with anxiety and depression over the pandemic. So these are very important numbers, and I really appreciate you sharing this with us. And hopefully we can address some of this during the talk that's coming. Okay, I'm going to now talk about our COVID action plan, and it's been up for a while, but it's important to revisit because we're constantly updating it. It has several resources for you. If you go to our website, you'll see a COVID button, and if you push on that COVID button, you're going to see the COVID action plan right near the top of that page. And it's going to lead to these step-by-step checklists. So on the left, you can see where the COVID button is, and then you can see where the COVID action plan is. Completing these checklists will ensure that you have a comprehensive COVID-19 plan in place, and you should do this in advance of when you need it. We've received really good feedback on this, not only from patients, but from their healthcare professionals. We find that it helps people with their anxiety. People have told us by having this in place, when they have tested positive, they've known what to do. When they've been exposed, they've known what to do. So it really helps you to be able to move quickly. And as you'll find out through the course of this webinar, moving quickly is critical. I'm also going to urge you that things are constantly changing. So we have these different areas that we look to, what to do prior to exposure. So this is just basic things like having tools around, like a thermometer and a pulse oximeter, and we talk about those things. And since we talk about how to isolate, quarantining, what to do if you have a confirmed infection, we have checklists for each one of these, and we recommend that you take a good look at these. We have a locator tool that will help you find Evusheld and other oral antivirals such as Paxlovid or Molnupiravir near you. We have a way to help you find the antibodies that you might need to both prevent and to treat COVID. And we just wanted to point out the news, and I'm going to go over this a couple times, that we recommend that monoclonal antibodies should be given within 7 days. This is a change. It used to be a little longer than that. And Molnupiravir is now seen as the treatment of last choice. The guidelines still recommend that everyone who's immunocompromised stay up to date on their vaccinations. We no longer use the word, "Are you boosted?" because the vaccination protocols are changing with some frequency. So up to date is the language we use. There's a new locator tool that will help you. We talked about that. And there are abilities, and we'll share that with you, to get free home tests. Now I'm going to talk about what launched today, and that's the test to treat that was mentioned in the State of the Union. And what this is if you can now go to one site, and these are listed on the website that's on here, and you'll have access to this after the meeting, where you can go and be tested. And if your test is positive, you can walk out with an appropriate prescription for the therapy. It's to expedite this. This is not only open to immunocompromised, but this is open to everyone. I do want to point out that if you're nervous about going into a site where there might be other positive COVID patients and you don't know whether you're positive or not, that you can be tested at home and just share those results on the frequently asked questions page. Just a verbal response saying, yes, I tested at home, I'm positive, is all that you need. You'll also continue to be able to get these medications through the channels that are already open at multiple other pharmacies through healthcare with the healthcare provider's orders. So we'll see how that works out and how chaotic or smooth the first day's rollout is. Here, I'm just going to point out one other thing on the test before treat. Locations are going to be CVS, Walgreens, and veterans hospitals, but keep checking back because that's going to change over time. The drugs that'll be available are Paxlovid and Molnupiravir. That is going to change. We have a link to it through us if you have trouble with the government direct link. So now let me introduce Dr. Josh Hill, an infectious disease physician and who's been involved in some really breakthrough research on the use of remdesivir, which he may touch on here, which is another option, but you need a doctor's prescription to get that. So Dr. Hill, I'm going to hand it off to you. Thanks so much.
Yeah, thanks, Dr. Kaufman, and hi, good morning, everyone. It's a pleasure to join for the session today, and hopefully we help to answer some questions as we go through here. I'll try to keep this brief and to the point and allow time so that we can touch on some questions later on in the session. So I thought it's always useful to kind of reframe the risk profile for, first of all, getting COVID and then getting more severe infection from COVID, as this really pertains to our current approach to treatment and prevention and use of the currently available medications for those purposes, the reality of which is that they're not as available yet as we would like them to be. And that's forced our hand to risk stratify and kind of help steward who gets these medications at highest priority. This is a slide that I've used courtesy of Dr. William Werble, who's at Johns Hopkins, and put this together. Many of you have probably seen something to this effect and certainly have heard about it and know a lot of this already. But just to review here, thinking about different risk factors. So first, with age, we know that older individuals have increased risk for worse outcomes from getting infected with SARS-CoV-2, particularly those above the age of 70. And we recognize that patients with CLL tend to be older and later in life. And so, most individuals are in this 50 or older area of this risk curve. Having comorbidities or other underlying medical conditions in particular types can also increase your risk, specifically people with heart disease, lung disease, diabetes, obesity. These are some of the key risk factors that we've understood from pretty early on in the pandemic. And in those who have 2 or 3 or more of these, plus other risk factors like age, et cetera, certainly risk goes up for having more complications related to COVID-19. Vaccination status is a critical component of all of this, and probably the most relevant aspect of both preventing getting initial infection with COVID, as well with SARS-CoV-2, as well as reducing the severity of illness if you do get infected. So this is probably the most important thing in all of our tools that we have to prevent people from getting very sick. And indeed, this vaccination is the most important tool we really have for most infectious diseases, aside from SARS-CoV-2. So being fully vaccinated, which means now having 3 vaccines plus the 4th booster dose, is critical. I think we are trying to avoid this booster terminology because that is a moving target, but receiving all 4 doses, I think for our high-risk patients is critical, and risk is highest in those who are unvaccinated. But even just partial vaccination can help, but there's incremental help by each additional vaccine that you get. And then finally, thinking about immune suppression. And so, patients who are the most high risk are those who have received a solid organ bone marrow transplant, have received a bone marrow transplant, or have an active hematologic malignancy who are undergoing therapy, particularly those with treatments that affect their B cells. And this is really where most where a lot, not most, but a lot of patients with CLL live in this higher to highest risk category of having an active malignancy if you're getting therapy with drugs like ibrutinib, et cetera. We know that this is a very high risk group for potentially advancing to more severe disease in isolation, right? And if you've had all of these vaccines and other interventions, this has really shifted a lot now, but this is the high risk group. And then the risks kind of are laid out here for other groups that are ultimately at lower risk as well. So these are important things just to think about what your own personal risk may be. But once you start combining different variables here, your risk may go up or it may actually go down quite a bit. All right, so here's a slide. It's busy. I'll walk you through it here, just giving a kind of overview of what the therapeutic landscape looks like for COVID-19. This was from an opinion piece or an editorial that was written in the New England Journal of Medicine after a paper that I was involved with came out about using remdesivir, an antiviral drug, to treat COVID. And it was a good time to reset and try to look at what the options are that are on the table. And we've actually updated this because things change very quickly in this space, and we've made a few modifications to it. So let's start on the far left side of this slide here. Looking at along the bottom is telling you kind of where an individual person might be in the course of being out of the hospital, in the hospital, uninfected versus exposed but not yet infected versus having infection. So starting with people who are outside of the hospital, are not exposed necessarily, have not been infected, how do we prevent infection? And so vaccines are really the foundation of this. I don't think we need to belabor that too much here. But the other critical piece of this for people who can't respond to vaccines well, obviously, which is the main concern of most people with CLL, is additional support. And so the goal of a vaccine is to give you a boost in your immune response. That's giving you antibodies and giving you T cells to prevent and then contain infection. But many people with CLL may not have a good antibody response. So we can bypass that by manufacturing antibodies synthetically and just giving you that immune response, giving you the antibodies that you were unable to make yourself through the vaccines. And that's the concept of these monoclonal antibodies. That's the concept of Evusheld. That's giving you the immune response that you need because your body wasn't able to make it on its own by getting vaccinated. So Evusheld is kind of the main tool that we have right now to give people that antibody response that you otherwise might have had if you were a healthy individual getting vaccinated to prevent you from getting infected in the first place. This has not been studied and is not yet approved for giving it to you if you are infected. So this is uninfected, and this is an important piece of the puzzle. This is limited in access right now, unfortunately. We're working on that. The efficacy of this, or how effective it is at reducing infection due to some of the new variants, like the Omicron variant, is changing. And the virus is mutating, and it's not as effective as it used to be. But now we think that increasing the dose of it can still be effective. So this is an important piece. All right, moving on to the next column on the right side of this slide. In those who are exposed, theoretically, you had an exposure, but you're not yet infected. There's no evidence that you're infected. In that context, we can give some monoclonal antibodies, so other antibodies, similar concept as Evusheld, that have been studied. But unfortunately, the ones that have been studied are no longer effective for the circulating variants. So that's sort of off the table for now. But I imagine that those will be updated moving forward. So that's not a great option right now. But on to the next category here, now you are documented to have an infection, but you're not in the hospital, you've got mild symptoms, but if you're at risk for progressing, that's where we try to give you a different set of antibodies that have been studied for this purpose, that reduce the risk that you have severe complications, that you go to the hospital. That's the goal here. We want to turn this into just a mild upper respiratory tract infection like the common cold. For that, we currently have 2 monoclonal antibodies that are effective for the circulating strains of SARS-CoV-2. One of them is sotrovimab. That's the one that's been around for a few months now. And the new kid on the block is this bebtelovimab. This is the newest one. We, as far as I'm aware, still don't have access to this in our system here in Seattle. I have not prescribed this for anyone yet. And sotrovimab as well has been limited, and access is not great. When it's given, this can reduce the risk of getting hospitalized by up to 80 to 90%. These are really strikingly effective at reducing risk, but they're not perfect. And access is still limited. So because of that, we really prioritize our highest risk patients, which is related to the slide that I showed you before. And most individuals with CLL getting active therapies that affect their B cell function are eligible for this. But again, we have to steward that. And I'll talk a little bit about, other aspects that we consider and when to give these therapies. They're really most effective early in the first week or so after infection. There are some antivirals available as well. There's molnupiravir, there's Paxlovid. Those are oral, and then there's remdesivir. This is an IV antiviral, but this is required to be given remdesivir for 3 days IV. So this limits access quite a bit in the outpatient setting. And then finally, for people who are unfortunate enough to develop more severe symptoms and do require hospitalization, we have a few anti-inflammatory medications that we'll use in that context in patients who are hospitalized. These are baricitinib, dexamethasone, a type of steroid, and tocilizumab. So you might get a combination of these. Dexamethasone is the most common one we would give to someone who's hospitalized. And if you get hospitalized due to COVID, typically we're using remdesivir as well. This is a drug that works on the virus. It's an antiviral combined with something like dexamethasone, an anti-inflammatory. So that management of patients in the hospital has really not changed in the past year or two. That has been our standard of care for a while. And most of our efforts have appropriately shifted to the outpatient world, not hospitalized, but trying to prevent people from getting there. So this is a very busy slide. We can just touch on this from a very high level. But this is a little bit of a decision tree that's used for healthcare providers to navigate this. It's a complex landscape. There's antibody therapies, there are antiviral drugs, and all of them have different indications and different contexts, and depending on how far out you are from your infection versus other side effects that the drugs might have, whether they interact with other medications. So it's complicated for people to think through and sort through. And it's going to be complicated for this test to treat strategy for people to navigate this for individuals that are on multiple medications and have other comorbidities or lab abnormalities. But the high level here, just thinking about things is, first of all, are you hospitalized or are you out of the hospital? This guideline is really for people who are outside of the hospital. And the key criteria here now is, are you early in your infection or not? Are you within the first 5 to 7 days or not? And the reason that that's important is because, first of all, that's how a lot of these studies have been designed that have shown benefit or not. And also because we've learned that intervening beyond that first week tends to be less effective. A lot of these drugs lose their benefit after that time point. Now, that needs to be taken with a grain of salt because most of those studies have primarily been in healthy individuals or individuals with other risk factors, but there's no big study that has done this for patients with CLL, for instance, or other hematologic blood cancers or hematologic malignancies. So it's possible that outside of those windows, other immune compromised patients may still get benefit. The issue is for some of these drugs that haven't been fully FDA approved yet, we have to use them within the confines of how they were approved by this emergency use authorization. So legally, sometimes we can't use it beyond a 5 to 7 day time period, but that's the time to intervene. And that really underscores the importance of getting tested when you have symptoms and figuring this out early so that we've got the most number of tools that we can offer to help prevent progression. We also have to think about whether a patient has kidney disease or liver disease. That affects some of the drugs that we might choose. But for our high-risk patients, like patients with CLL who are within the first week after therapy, our kind of first priority is a monoclonal antibody. We want to give you a single intravenous infusion of either sotrovimab or bebtelovimab. These are single infusions, it's one dose, and if you can access them, that's what we want. They have low side effect profiles and up to 80 to 90% benefit in reducing the risk that you get really sick. So that's our go-to. If we can't get you one of those, the next step is trying to get you Paxlovid. This is the Pfizer drug, has to be given within 5 days of symptom onset. It's an oral pill. It's 6 pills a day, and it interacts with a lot of other medications. So that's something that we can typically navigate. We can hold other medications for a short period of time. It's easy to take. It's at home. So that's a nice option if you can access it. There's the intravenous remdesivir option, but that's 3 days IV and very challenging for most sites to access and to implement. So that's not so available for everyone unless you're in the hospital. Finally, there's molnupiravir, which made a big splash in the media. Initially, we were very excited about it. It doesn't have as many side effects and drug interactions, but ultimately it doesn't seem to be as effective in preventing progression. And, this is much less effective than the other interventions. So it's an option. We're not using it very frequently in our immune compromised patients. We just don't think it's the right drug for most people, but it is an option. So yeah, that was a high level. There's a lot to digest there, but I think we should just keep moving here. And navigating that decision tree is more for your healthcare providers than for you as the individual. This is just the last slide to talk about, the reality that we're all seeing now is that the landscape is changing once again. The second you get used to the new normal, that shifts on us. So this is focusing on this new variant of Omicron, called the BA.2 variant, which is the new mutation in the virus that's now spreading more rapidly and starting to overtake the initial versions of Omicron, sort of like we saw with Delta and with Omicron, et cetera. So this is the continued evolution. The proportion of cases that are due to this new variant are increasing relatively quickly. We're not seeing the explosiveness of the original Omicron variant. It's not quite as concerning as that. And this is just showing you in pink here, what this has looked like on a weekly basis, the proportion of positive tests that are with this new variant. And you can see it's becoming more and more frequent as the cause of SARS-CoV-2 infections. And you can see here, depending on what region of the country that you're in, the relative proportion that are due to this new variant, which does have some new mutations, which may affect how well some of these different medications work. So it's increasing, it's concerning, but in Washington state, at least, we haven't seen this necessarily associated with a rising number of cases and hospitalizations necessarily. So we're hopeful this won't be anything like the Omicron wave that we saw with the first version of it, but this is something that we are watching closely and is keeping us on our toes as always. I think that's it for my slides. We can advance one more. And yeah, I'm happy to pass this on to Dr. Parikh and happy to answer some more questions in the next session of this talk today.
Dr. Hill, thank you so much. That was incredibly helpful. We're going to have now the experience and approach of someone who is a CLL expert, world-renowned CLL expert. Dr. Samir Parikh is a good friend and is going to talk about the specifics of COVID-19 and CLL patients from his experience in Rochester, Minnesota, and dealing with his colleagues at Mayo Clinic across the country. Dr. Parikh.
Thank you very much, Dr. Kaufman. It's very nice to be here. I thank you for the invitation. Good morning and good afternoon to wherever you are. I just want to spend the next few minutes to talk about how we've been thinking about COVID-19 infection with our patients with CLL. Obviously, as you just heard from the excellent presentation of Dr. Hill, I think this is such a rapidly moving field that I think if you don't see your doctor for 3 months or you don't, follow up with the latest that's going on with whatever source of information you get from, you can actually be, left behind. And I think it's very important to keep up to date with where things are. And unfortunately, the onus is really upon patients. And again, I think this is where, smart patients get smart care is really very apt in this day and age. So this is a schedule. And again, the highlight here is it is a revised COVID-19 vaccination schedule. And I think the revision really is where you need to keep up. So, we all know about the 3 doses of the mRNA-based vaccines, both Pfizer and Moderna, that were approved last year. And I think the 3rd dose was sometime in the middle of August. Now, when I was seeing patients in December and January, the fourth dose was being touted as something that should be given to patients after 6 months from the third dose, and it became 5 months, and now it's 3 months. And so I think, if you last saw your doctor in maybe December or January and haven't seen them since then, you probably may not know that now they've changed it to 3 months after third dose. I think it's important to make sure that you actually all get a fourth dose of the COVID-19 vaccination, both of the mRNA-based vaccines. Janssen vaccination has really been one of the difficult ones to deal with, because for the longest time there wasn't an additional dose recommendation. But for the most part, I think the recommendation still remains that you should get an additional dose of an mRNA-based vaccine at least 28 days after the first dose. And then you should also get a quote unquote booster or a second dose of any of these mRNA-based vaccines, either the Pfizer or the Janssen vaccine. So I think, this really illustrates the vaccine responses that we have seen in our patients. On your far left, you will note that compared to healthy controls, patients with CLL have about a 50% chance of developing an antibody response. And this is to 2 doses of either Pfizer or Moderna vaccine. And in the middle, you will note that the patients who are on therapy for CLL actually have a far lower chance of developing an immune response compared to patients who are treatment naive, meaning they've never received any treatments before for their CLL. And then on the right, in that same middle graph, you will note that patients who have received therapy in the past but are in remission are able to mount an effective response to vaccination. Now, again, a couple of caveats that I want to point out over here are the fact that our patients that are treatment naive, meaning you have CLL for about 5 years, you've never needed treatment, the response to vaccination, and again, this is antibody response alone with 2 doses, is lower than healthy controls. And so, we still continue to think of these individuals as immunocompromised, not responding well to vaccination. And this is an important piece that needs to be remembered. Unfortunately, many of our patients who have never been treated don't really get the things that, we would want them to get, like Evusheld, et cetera. And I think that really is concerning, but hopefully as the supply, expands, all of these patients will also be able to get all the medications that we think are so important. And then on the far right, you will note that patients who have received 2 doses of the vaccine have about a 50% response, and with a third dose, a quarter more respond to the vaccine. But after 3 doses, roughly 1/4 of all patients still do not have any antibody response. And I think the data are still lacking about the efficacy of a 4th dose. We also actually have to point out that the data about T-cell responses, et cetera, are still in their infancy. And so this is an important caveat to be remembered. And one final thing that we have to mention is that these are antibody responses, which don't necessarily translate directly into clinical efficacy, meaning how protective. So we can't tell that an X amount of antibody titer that you may have measured through a lab test is going to protect against infection. Unfortunately, that correlate of protection is not readily available. And so I think as we think about all of this, we go back and forth about what does this mean? How do I go about doing things that I like, that I've always done in my life? And I think the one thing that we still continue to advocate is you should get all the vaccines, get Evusheld if you're able to, but still continue to act like you're not vaccinated, because we still don't know the efficacy of all of these medications against the new variants that may be out there, and it is still a moving target. Next slide, please. And so I think a lot of people already know about this. I think the key that I'd like to highlight here is that this is passive immunity, meaning these antibodies have been made for you, as opposed to asking your body to make the antibodies to the vaccine that may be administered. And so this is something that is very good. Even if we don't know the efficacy of this particular long-acting antibody against many of the variants, it would still be good to get the antibody because something is better than nothing, at least in my opinion. I think there will be changes to how this is done, in that right now we think every 6 months is something where this antibody is likely going to be needed to be administered again. However, we also just saw that the dose of the initial Evusheld injection was doubled. And so I think there are a lot of things that are changing. And again, we'll have to keep up to speed with how things go. Next slide, please. And I think this is my final slide. I think as we all care for our patients with CLL, on your left, you see that there are a number of very effective treatment options for CLL, including BTK inhibitors, BCL2 inhibitors, antibody treatments, etc., in combinations thereof. And in addition to all the factors such as age, fitness, the genomic characteristics of CLL, all kinds of comorbidities that we think about, I think a big factor that has played into our decision-making process is COVID-19. And I think this has really affected our ability to deliver effective treatments. But I think we are grateful that there are many treatment options available. And I think before making a treatment decision, having a very good communication and a sort of a risk discussion, risk-benefit discussion with your hematologist and oncologist is definitely the way to go to try and understand what treatments would work best for your individual CLL. And so with that, I'd like to stop. I'm happy to answer questions. Thank you.
Dr. Parikh, thank you for setting the table for us here and covering a lot of material, and I think answering a lot of the questions that were available. And Dr. Hill, thank you very much to here. And we'll start with some questions. And I'm going to start with the biggest general question. And I know that this is not going to be a one-size-fits-all, but it's the underlying question. Somebody's now been fully vaccinated. They've received their Evusheld. When can they return to society? When can they start to live their life? What are you looking for to say it's safe? Or I know it's a nuanced answer, but it's the underlying question. And it's not I have a lot of specific questions, but I have that general question asked 20 different ways so far. So Dr. Hill, do you want to take it first in terms of what are you advising your immunocompromised patients?
Yeah, that is the million-dollar question, and there's no one-size-fits-all response to that, of course, both from a scientific medical perspective of all the different variables that any given individual brings to the table with comorbidities, underlying conditions, age, these risk factors, as well as where they are in their treatment course. But I think we are at a place now where we can start helping people kind of navigate this. And yeah, the reality is, all right, so getting your vaccines, we understand that a lot of people on this call probably won't have a great response, but the great news about that is we have somewhat of an answer to that, and that is Evusheld. And so if you're able to get that, that is theoretically giving you a component of the immunity that you really need that you're lacking from the vaccine. That's giving you that antibody, which, the goal of that is to really prevent you from getting infected. Vaccines do have some other components that stimulate other parts of the immune system besides antibodies. The vaccines are still important because just what we know also in patients with CLL and other cancers is that even if you don't generate the good antibody response, some of those patients are still developing the T cell response, which is another important component of the immune system, which can help fight infection once you get it. So I think that is an important aspect of understanding. You should still get the vaccine, even if you aren't going to get a good antibody response. Don't be discouraged. There are other benefits to it. Plus the Evusheld that's giving you that antibody protection. I think that already puts you at a good spot, right? And the other reality is that we do have other interventions now. We aren't where we were 2 years ago. We've got great testing that can, let you know really early whether or not you're infected. And we do have interventions if you do get infected. We do have some antibodies. We do have antiviral medications. And if you were to be unfortunate enough to get infected and progress and get hospitalized, there again, we've come a long way. We know how to manage people when they get into the hospital. We know how to mitigate, more severe complications, and we have interventions that work. So, it's a little bit of the Swiss cheese approach where we have lots of different tools now that we just didn't have when all of this started. So I think we can navigate this a lot more. And I think that should be reassuring to people. It's not a blanket, rubber stamp assessment that says, hey, go out and just live as if, COVID never happened, because we're not exactly where we want to be yet. We don't have Evusheld for everybody that could benefit. We don't have antivirals that are really readily accessible for everyone that could potentially benefit, but we're doing pretty well with that, I would say. The variants are throwing a little bit of a bump in the road related to that. But, I think if you're an individual who has gotten vaccinated, has gotten Evusheld, and are making reasonable decisions, I think it's fine to get back out into society now. I think it's appropriate. I think wear a mask when you're in high exposure situations. If you feel more comfortable doing that, I think that's a good idea. If you're doing things with family or friends where people aren't going to be masked, it's okay to ask people to take a rapid test at home, right? These are now freely available through lots of resources. You can also, purchase these in most places. Hopefully that's more accessible as well. So there's lots of different steps using the Swiss cheese approach that you can take to really mitigate your risk of getting exposed in the first place, getting infected, and then hopefully getting the care you need if you do get infected. So, we're getting there. We're closer to that reality. I'd love to hear Dr. Parikh's, assessment too, and how he's talking to his patients about it. I don't think this is as I mentioned, a license to just, it's all about your risk, your risk aversion and how you think about this. We know this virus is out there and it can cause problems for people. I don't think it's this, as scary as it once was, because we do have so many more tools now.
No, I thank you. I couldn't have put it any better. I completely agree. I think, we are in a much better position than where we were 2 years ago, clearly. And I love the Swiss cheese sort of, analogy here, because I think every layer of protection that you can get yourself equipped with, including masking, including vaccination, including the 4th dose of the vaccine, including Evusheld, including making sure that should you get infected, unfortunately, and you're not in your home, you're visiting someplace, what kind of resources will that local place have for you to be able to get, the medications that you will need. And I think that kind of preparation is really what I think all our patients need to know and plan for. And I think, again, it's not a black or white sort of a thing. I think it's completely gray, if I can say that, because it's not, very straightforward. But I think increasingly, we see, and I've seen in my clinic in person, patients who, the mental toll has really been really, really hard for a lot of our patients, not being able to do the things that they enjoy. And I think, if you make careful decisions, I think, it is possible to be able to get back into doing what you like.
Thank you. And, I think if there's one thing that COVID has taught us, it's to be humble and to realize that whatever we know today will be out of date tomorrow, and that all scientific knowledge becomes obsolete at some point. But I don't think I've ever seen anything so fast. You just learn about one variant and then you're completely out of date. Let me go to some more specific questions. And Dr. Parikh, you mentioned that the timing of the booster dose, the 4th dose, is shifted. Can you remind us what that is? And what if a patient is past that window? Does it matter? Should they still get the dose?
Yeah, no, I think so. That window is about 3 months after the 3rd dose for both the mRNA vaccines, so both the Pfizer and the Moderna vaccine. And so I think at a minimum of 3 months after your 3rd dose, you should get that 4th dose. But I don't think that there is any specific upper limit to that. So if it's been 6 months after your 3rd dose, you should still go ahead and get the 4th dose. I don't think it matters, the upper limit. The minimum is 3 months is where you have to wait between the 3rd and the 4th doses.
Yeah, and I've seen a lot of questions popping up related to vaccine timing and timing with respect to Evusheld. None of these are hard and set. If you're 2 weeks early or you're 2 weeks late, go for it, get the vaccine. If you're going to go on vacation and you need to get this a couple weeks early, that's okay. It's still safe. I think that's still fine. There's no magic to these numbers. It's, we're slowly refining and fine tuning. But at the end of the day, get it when you can get it. If you've got an Evusheld, just get your vaccine. There's no restrictions anymore that we recommend to getting vaccines. So it's safe. It's all a balance of, when might be the exact optimal time to get it. And, there's no perfect answer there. So yeah, I agree. Just get your vaccines when you can get them and follow the guidelines if you can, but I wouldn't be too worried. I wouldn't worry and stress too much about the fine details there.
So Dr. Hill, let me push you on that in the timing of the vaccines and the Evusheld, because what I've heard is that it was best to get vaccinated and then wait a couple weeks to get the Evusheld. And then let's do the flip. You've got the Evusheld. Wouldn't the Evusheld block the efficacy of the vaccines in theory, and maybe even the vaccine blocks some of the efficacy of the Evusheld, use up the antibodies? What's your guidance on that? How's that science evolving?
Yeah, we were initially being a little bit more cautious around all of the monoclonal antibodies and when you get your vaccine. And, because of these theoretical concerns that one could block the other, and, getting the antibodies first might prevent you from generating a good immune response. That's all been theoretical. It's something we've thought about for a long time with IVIG, is just this general immunoglobulin product that some people get before all of this COVID stuff to help support their immune system, and with CLL and other conditions too. And we've been cautious before about the timing of vaccines there. I don't think that's really played out, and the data don't really provide a strong argument that Evusheld interferes with the vaccine and that the vaccine interferes with Evusheld. At least that's my understanding of the last time I looked at the data. So it's a theoretical concern. If you've got a little bit of flex there to wait a couple weeks in between, that's great, but I don't think I would, again, stress too much about it, and get it when you can get it. Yeah, I guess that's where I would land with that.
Dr. Parikh, anything to add to that? That must be a common question.
Yeah, no, I think so. It keeps changing all the time, but I agree. I think, regardless of what, you are being told, I think it's easy to, get the vaccines a few weeks here or there. I think there might be some restrictions from individual practitioners and organizations where I have also heard that you have to wait about 2 weeks to get your 4th dose after you get Evusheld. And if that's the restriction that is being, told to you, I think you can't do anything about it. You got to live with that. But as soon as the 2 weeks are up, go ahead and get your vaccine.
Here's a question that's come up in different ways, and I'd like your take on this. Immunocompromised patients, CLL patients, are very dependent on the cocoon around them, their family members, their caregivers. A lot of times at similar age to the patient, so they're older and they have some comorbidities, but not, usually not immunocompromised to the same extent. Should they be getting a 4th shot? That's not, on label at this point. What are you talking to the partners of your immunocompromised patients about a 4th dose? And do you see that changing in the future? Dr. Hill?
Yeah, it's a good question. I mean, this is a question my parents just asked me before their planned trip up here to visit. And, it's not yet recommended by, the CDC or by the FDA here. It's, Dr. Fauci has talked about it. And there was recently data from, I think, Israel that was published looking at healthy young, healthcare workers. And it didn't seem to provide a whole lot of additional benefit there. I think it's likely safe. We haven't seen any safety issues around it, but I don't know that it adds a lot. If it adds 10 or 20% additional protection, that's not nothing. And I think maybe that's relevant. I don't think we're quite there yet to make the blanket recommendation. So, this might change. I'm not sure what you're recommending to your patients, Dr. Parikh, but yeah, we're not quite there yet to make that as a routine recommendation.
Yeah, I think it's challenging to advise that to relatives of CLL patients who are not immunocompromised, because I think, if I know this correctly, I think both Pfizer and Moderna really recently submitted for a 4th dose. In I think Pfizer was for greater than 65 and Moderna was across the board. And I think until there are recommendations from the CDC with respect to a fourth dose, I don't really think that we would be recommending a fourth dose outside of the usual sort of recommendations.
Let's talk about that fourth dose in terms, there's been some data that suggests that the durability response may be a little better with Moderna than the Pfizer. And there's some data on mixing and matching vaccines. How are you approaching this with your patients, Dr. Hill, for immunocompromised patients? And let's say the patient has not had a good response to their first 3 shots. Are you suggesting switching, or where's the science and the official recommendations in terms of mixing and matching vaccines?
Yeah, it's not really there yet in any sort of a distilled way that we could make a really educated or informed recommendation about it. I think mixing different types of mRNA vaccines, so the Moderna versus Pfizer, I don't know that there's a whole lot of benefit to that. Typically when we think about mixing vaccines, we're talking about 2 different, vaccines with different mechanisms of action, kind of like the J&J vaccine versus the Pfizer or Moderna, which just have a different, they've got different components to them. So yeah, and then, the difference between Pfizer and Moderna is to some degree, splitting fine hairs there. It's not, I don't know what the clinical relevance is of that. And it's a little bit difficult to really firmly say, hey, I really want you to get this versus this. I think we definitively can say, if you've only gotten 1 dose of the J&J, that's not sufficient. We want you to get the mRNA vaccines, which, seems to be a more robust regimen. And mixing those, yeah, has had some benefit, but we're not routinely recommending that people go out of their way to mix vaccines. I think if you haven't had a response to the first 3 vaccines, it's more a reflection of your immune system than a problem with the vaccine. And putting a different type of vaccine in there may not add that much benefit. So yeah, I think we're just not there yet for a definitive recommendation.
Okay, and I think I already know the answer to this, but I'll put it out, the last vaccine question for now, at least, so we can move to some other topics. A 5th dose, Dr. Parikh, any research going on that? Any thoughts? You must have patients already approaching you about a 5th dose. I already know people who've gotten a 5th dose, so.
Yeah, no, you're right, Dr. Kaufman. I think there have been many patients who have gotten 5, 6, 7, 8 doses of the vaccine with no response. Like Dr. Hill mentioned, a reflection not because of the vaccine not working, but just their immune system not being able to mount an effective response. And I don't know, how effective a 5th dose will be. I hope that by that time, Evusheld is much more generally available, such that, I would much rather have patients get that as opposed to, getting a 4th or a 5th dose of the same type of vaccine with, 0 antibody response. And the other thing I think, we also have to acknowledge and remember that, like Dr. Hill mentioned, there are many other aspects of the immune system that, are really working, that are not easily measured, that, will continue to provide protection. So I would say 5th dose is maybe on the cards. At some point, everyone's going to get it. But I would much rather think about alternative ways such as Evusheld to provide more protection.
Let's use that as a segue to Evusheld. And let's start with a very common question. If you've had a good antibody response, this is for you, Dr. Parikh, to the vaccines, do you recommend that your CLL patients do, because some of them do, as you showed, still get the Evusheld, or if they haven't had an antibody response, do you still recommend it? Or if they're in that group, like they're treatment naive or and they're at a deep remission, do you still recommend, or you're only recommending for your patients on therapy that they get Evusheld?
So currently, because Evusheld is limited in supply, I think we are constrained by who can receive it. And I think currently it's only patients who are on active therapy or who have completed treatment in the last 12 months are the patients that are able to get it. Ultimately, I hope that everyone is able to get it, including all immunocompromised patients, regardless of their treatment status. I don't think it should really matter as to what your antibody response is to the first 3 or 4 doses of the vaccine. I think everyone who is eligible to receive Evusheld should get it. I think it's the way I think about it is it's an IVIG preparation that I give to my CLL patients who have frequent risk for infections because their IgG levels are low. And those IVIG antibodies will actually protect against a wide variety of infections. And I think of Evusheld as a very specific IVIG that is a long-acting IVIG against COVID-19 or SARS-CoV-2 in particular.
Dr. Hill, how effective is Evusheld, and is that efficacy against preventing getting COVID or preventing hospitalizations and deaths from COVID, or both? Can you help us understand that? And the second part to that is how long it lasts, because I understand the guidance on that has changed recently.
Right. Yeah, I've seen a number of questions popping up around this, and also specifically trying to apply it to CLL patients in specific scenarios or with specific, stages of disease. As far as the granularity of specifically to CLL patient populations, I'm not aware of data that has, really studied that in this specific scenario. In the studies, typically, these studies are in patients that are considered high risk. They have whatever risk factor, whether it's cancer or something else. It is 80 to 90% effective at preventing patients from getting infected and hospitalized. So it is very effective in reducing those risks. And this is for about a 6-month period. So that's how it's been approved. So this is supposed to last for about 6 months. It's a little bit different than IVIG, which is given on a monthly basis. This has been modified so that it lasts longer and it circulates longer. And so theoretically, depending on where we are in 6 months, you might be eligible for another dose. And that might be an appropriate thing to do if you're still immune compromised, and if this hopefully is still active against the circulating strains of SARS-CoV-2 at that time. 6 months is kind of the time frame that we're talking about. But yeah, that's the goal here, is that it should be both preventing. We are seeing breakthrough infections. That is someone that got it and is now subsequently getting infected. How well it works in that case in preventing the severity of infection, I think we don't have a great handle on. And you are still eligible to get additional therapies at that point. If you got Evusheld and then get an infection despite that, there was a question I think I saw pop up, should I get one of the other monoclonal antibodies like sotrovimab? These are all slightly different. We don't know the answer, but yeah, I would say you should get the other therapies at that point that you're eligible for. So that's kind of a high level response to that.
And I'm going to follow up. I agree with you. I think COVID is not your friend, so you do what you can to prevent it. Another question is, Evusheld is only for pre-exposure prophylaxis. So if you've had COVID before and you're past it, you can still get the Evusheld, correct? Or is it only if you're actively infected you can't get it?
Yeah, it's just if you're actively infected, it's not a treatment for that. If you've previously been infected, gotten over it, sure, you can get it again. I think you should get it again if you're still in a high risk group.
Right. And there is some data that it has efficacy in those settings. It's just not authorized for use in those settings. What about the adverse events with it? Two broad questions. The first is there's been some concern about cardiac events. Could you put that in perspective for us? And the second is a lot of patients with CLL are used to getting monoclonal antibodies like rituximab or obinutuzumab, and they can have adverse events. They can lower your blood count. You can get low neutrophils. You can have other problems, low B cells with them, no B cells with them. What about Evusheld? Does it cause those hematological problems, and does it cause cardiac issues?
I can start, and maybe Dr. Parikh can also add to it. We're still learning with all of these, right? I mean, the trials are so limited. If you've got an event that happens in 1% or 0.5% of people, it's difficult to pick that out from a trial that has 100 patients or 500 or 1,000 patients. It's sometimes those can be a little bit obscured and hard to accurately estimate. In our experience here, we haven't had many issues at all. The main concern is an infusion reaction. Anyone can have a side effect to a new medication and something that's going in intravenously. So that's the main concern. Those are pretty readily, addressable in the clinic if it happens, kind of an allergic reaction. It's hard to put the heart potential heart side effects in context. Those are there with some of the vaccines as well. But, I don't know that we're able to predict who is going to develop those cardiac side effects if they happen. I don't think that having a family history or necessarily having cardiac disease is known to increase your risk of having a side effect from the vaccine or from Evusheld. So that's difficult. And then taking another step back, thinking about the other medications that people with CLL and with cancer are getting routinely all the time have a much more severe side effect profile than what we're talking about with Evusheld and with the vaccines. Getting rituximab, ibrutinib, some of these other things, do have very, notable toxicities that we tolerate because we need to give them to control your disease. I think the risk of getting COVID still far outweighs the potential risks from getting Evusheld, and that's where I land with the vaccines and the antibodies, is that in balance, it's a valuable intervention. And yeah, maybe Dr. Parikh can comment.
Yeah, no, I completely agree with that. I think, the risk of the cardiac toxicity is very small. I think, many of my patients have questioned, I'm on ibrutinib or other BTK inhibitors for my CLL that are known to increase, cardiac toxicity. Should I be worried about it? And I think in general, our answer has been, we don't really know enough about this. In the patients that we've done it, I don't think we've seen any increased risk of any adverse events. And so I think in general, again, to Dr. Hill's point, what is a bigger risk? Is it really the risk of getting Evusheld with a small, very, very small risk of cardiac toxicity versus really getting the infection and having more trouble with that? And I think that really needs to be thought about. And in general, I agree also, there isn't really a publication that has come out from the use of Evusheld and its efficacy. And so I think what we know is from the press release and from the FDA's fact sheet, which has some information, but again, I think the granularity of the data really is really awaited once the full publication comes out.
Talk briefly about lab tests. A lot of people are getting tested for antibody levels. Could Dr. Parikh, are you recommending that to your patients, and what do those levels mean? And I know they differ from lab to lab. If you could just comment on that issue generally. There was a lot of specific questions on that. And I'll add one thing. Can you test after Evusheld? Does Evusheld affect that lab level?
Yeah, that's a great question. And I think it's very important to recognize that, and Dr. Hill, please feel free to chime in as well. I think there is no correlate of protection that we know of, meaning I don't think we can say that X amount of antibody present on any test that is commercially available will guarantee that you will not get any infection from COVID-19. I think that correlate of protection is very hard to get. The other thing we have to also remember is that most of these antibodies that are tested for are not neutralizing antibodies or are not, antibodies that are functional. The function of these antibodies is not known. The other thing I think it is also important to remember is that the antibody tests, if they are negative, then I think that may be more important to know as opposed to whether they are there or not. Because in an ideal situation, those patients would really be prioritized to get many of these Evusheld, et cetera, passive immune approaches. But I think short of that, I think it's very hard to tell that, okay, you have X amount of antibody and you're going to be protective. And the final thing I'll say is that you've got to be careful as you interpret these antibody reports, because Evusheld is going to make the antibody test result become positive. We've had patients who have received IVIG for their reduced IgG levels, and they suddenly now have these antibodies against COVID that have become positive in the blood because there is the presence of these antibodies in the general IVIG pool. So I think as opposed to 6 months, 9 months ago, I think the interpretation of these antibodies has become far more tricky.
Yeah, I absolutely agree with that. I think the Evusheld will give you a positive. It will give you high levels of antibodies. So it's difficult to interpret your own response, but I suppose that's less relevant. If you've got the antibodies there, that's the important piece, and that's what Evusheld does. And I agree that a negative antibody test is probably more informative than a specific level. different centers are approaching this differently. At our institution, we are not routinely checking antibodies in anyone. I know some places do this, and patients can individually go out and get antibody titers. I use it on a case-by-case basis. If there's a specific question, we're trying to navigate, someone's risk profile. They had maybe an adverse event, a side effect to a vaccine. Should they get another one? And, we can try to get some additional data from this to help guide us. We don't know that magic level. It says you're not going to get an infection. Not, no level is perfect, of course. No lab value is perfect in medicine. We are learning with, and antibodies differ, but we are learning now that, once you get above a certain threshold for a handful of the different antibody assays, people are now doing the studies to say, how well does that indicate whether or not you've got functional antibody response? Is it actually working to neutralize? And, we're starting to see for a variety of different assays above 1,000 or above 2,000. Of course, it depends on the antibody, test that you're using. And that's what makes this so difficult, is there's so many of them. But we're starting to learn that, first of all, higher is typically better. And, typically above 1,000 or 2,000 on some of the ones we use here, we know is related to, all right, now you've got, some level of functional antibody capacity there. This has mainly been in healthier people. We don't know how well this works in immune compromised patients. And there's the other aspects of the immune system as well. So it remains challenging, but we can generate some information from antibody tests that can help us navigate certain complex scenarios sometimes and make an educated decision about how aggressive we want to be about trying to pursue another vaccine in someone that might have side effects, et cetera. But those are kind of case-by-case scenarios.
I'm going to throw a couple things in here just to add to this. All of these studies, as you mentioned, have been done on immunocompetent patients. So even if we find a level that's safe, we can assume that very few, if any, CLL patients were involved in that study. And the other thing is, it's not just the level of the antibody, it's not how many soldiers you have, it's how well those soldiers fight, as we're finding out around the world. And in CLL, we might have a good antibody level, but how good those antibodies are and how will they coordinate with the cellular immunity, with the T cells, all of those things are completely unknown. The vaccines weren't studied in CLL, and the Evusheld, while it didn't exclude CLL patients, didn't have a lot of CLL patients in their studies. So, and the same with all the other antibodies. So, these studies are beginning, they've stopped and starts because of the variants of concern. So I think that there's a lot of questions there that are unanswered. The last thing I want to comment on is that every place is different. And Dr. Parikh talked about what's happening at Mayo, but there are places here where now that they've kind of gone through, they have an adequate supply of Evusheld and they've given it to the transplant patients and the people in active therapy, people who are treatment naive, people who are not in treatment, people who've had an antibody response to the vaccine who have CLL are getting it. So the treatment naive and other people are getting it. So it's going to vary from site to site and what the supply is. And that's one of the big problems, is the supply has been haphazard. And the distribution systems are different in place to place. And the bad news that we learned earlier this week is unless there's a change in funding, the supply is actually going to shrink. And there was some press that the government thinks it might run out of the monoclonal antibodies before the end of the year unless there's new funding available. Evusheld, the lists that we so proudly put up on our website, we're finding out are terribly inaccurate, that there's all kinds of sites that have Evusheld that aren't listed and sites that say they have the Evusheld that are listed, the same with Paxlovid. I want to spend just a couple minutes on a couple other things. IVIG, its role in this, and maybe Dr. Hill, you can comment on convalescent plasma, which was a really hot topic, but seems to have fallen off the radar screen. Is that still got a role? And what about IVIG for prevention of COVID?
Yeah, I wish, IVIG, although it's more readily available, it's still not, this is a blood product that's made from, 1,000 different healthy donors that are pooled in to make this product. So it's incredibly expensive. There's been a reduction in the number of people, donating blood. There's been lots of shortages. there's an ever-expanding list of indications or potential indications for IVIG. So it's also not an unlimited resource that people can just readily get. So that's one thing to know of, that insurance companies may not cover it. You may not even be able to access it, unfortunately. But even if you were able to, the data just aren't there, unfortunately, and haven't ever really been for IVIG with other respiratory viruses. There really are no strong data that say IVIG is good for preventing or even treating respiratory viruses. We've looked at this in different ways. Theoretically, it's a nice idea. We try it, but there's no great data to really support that. It doesn't have an FDA indication for preventing viral infections specific, or most respiratory viral infections. Really, it's indicated for preventing bacterial infections. And that's where we get the most bang for our buck. So, I don't think there's a great role for it. I think it might give a little bit of a false sense of security. It's not crazy to try it, but that's just kind of my take on IVIG. I think for convalescent plasma, access to that is even more challenging. There's so much variability in how good of a product can be made from a given person or from a given lab. And really what we've seen is that you might have some benefit from the really potent, concentrated, really high levels of convalescent plasma, but it's tough to make that. I think from a pragmatic scale, it just really hasn't panned out for hospitalized patients. It doesn't seem to be that effective, maybe in the outpatient setting, but it's not really a pragmatic or practical thing to give. Really what we need is the synthetic monoclonal antibodies that we're talking about, that we want, Evusheld, sotrovimab, that can be mass produced on a greater scale than you can ever get from making convalescent plasma, which is taking blood products from people who were previously infected. It's just complex and not really an answer to this problem.
A couple other things. People asked if you've already received half the dose of Evusheld, do get the other half of the dose. That's the recommendation. That's a universal recommendation. And now what everybody is doing is getting the new dose, which is usually 4 shots, 2 shots in each cheek of the buttocks, is the way it's done. Sometimes it's 1 shot, depending on your size and muscular build. Won't go into too many details there. I have to ask you one MBL question, Dr. Parikh, because I know you've done a lot of. Is it any difference for people with monoclonal B-cell lymphocytosis, the precursor, in some cases, to CLL? Are you having the same recommendations for those people?
Yeah, thank you, Dr. Kaufman, for that question. I think, in general, we think that individuals with MBL also have the same amount of immunosuppression or immunocompromise compared to, patients with untreated CLL. And I think, in general, we try to follow the same recommendations for these individuals as well. And I think, again, it's the same sort of discussions about risks and benefits of what we've just talked about, and the ability to get Evusheld and other, such products to our patients. And I think, in general, we try to think about individuals with MBL and previously untreated CLL in the same category.
If you can be real quick on this, Dr. Hill, any thoughts on combinations using the antibodies and Paxlovid or 2 different antivirals? Is there research going on? And one thing I got to ask, I take acyclovir like a lot of people do to prevent a viral infection. Is there research going on to maybe take Paxlovid on a low dose to prevent COVID? People have looked at ivermectin in this way, which has, had very mixed results to stay out of the politics of that. Yeah, that's a great question. I think combination therapy is where the field needs to go and ultimately will go. I think it's going to take some time before we get there, but like we know for other difficult to treat viral infections, particularly in immune compromised patients, you need to attack it with multiple approaches like we're already talking about today and doing. And I think combining these is a very appropriate strategy. We don't have those studies yet. I'm not aware of any that are doing them yet. And because of access, I think you're unlikely to be offered 2 different types of approaches, because we're really just trying to make sure we can treat the most number of people as possible. But I think that's going to be the future. And then as far as prophylactic, preventative, something that you can take on a daily basis, that's the niche that Evusheld is filling right now. And I think it's a very effective one.
Will there be a role for a pill that you take instead of Evufitreld in the future that you take once a day? Maybe. I think it would have to be incredibly safe, and you would have to have a pretty high circulating, likelihood of getting infected to make it worthwhile. I haven't seen any of those studies yet.
We're going to close here. There's a million other questions that we didn't get to, and really great questions, but hopefully we covered a lot of the common things. Dr. Parikh, any final thoughts?
No, I think thank you very much to all the attendees. I think this is obviously a challenging clinical scenario. I think we all take care of our patients on a regular basis with these questions that come up all the time. And I think the one thing that I would say is make sure that you talk to your doctor about where you are in your journey for your CLL diagnosis, and think about multiple different ways of what we've discussed today of how you can protect yourself.
Dr. Hill, you get the last summary statement here.
No, I think Dr. Parikh just summarized it nicely, and this was a really great conversation. Thanks for being engaged in your interest. I think just showing up to these sorts of things indicates that you're getting educated, you're taking the right steps, you're asking the right questions. I imagine, there is going to be frustration here because you're going to get different responses from different people, and there is no right answer here, as is typically the case in medicine. There's just a lot of gray. But I'm hopeful that this has reassured some of you about, what steps you can take to try to, start reintegrating into society in a safe way that's appropriate for you and your family.
Thank you. I want to thank the grant support we received from Regeneron and Janssen and Pharmacyclics, without whom this wouldn't be possible to do. And a huge vote of thanks to Dr. Parikh and Dr. Josh Hill for, I think, what was a really dynamic discussion. If we didn't get to your questions, and I know we didn't get to a lot, there's a link here. Every slide that we showed will be available to you. These will be up. All the links will be up. Our next webinar is in April, and it's going to be very interesting. We have an expert in exercise in CLL with a study showing improved immune response in people who do high intensity interval training out of Duke University, a study there. We're also looking at healthy diets and a healthy psychological approach. This is a very common topic. It's going to be a really great webinar, so please join us. The CLL Society is invested in your long life. Please invest in the long life of the CLL Society. Remember that we need your feedback. You're going to be receiving an event survey. The event was recorded, so you'll be able to see that. Thank you very much. And as I always close up, stay strong. We're all in this together, and I look forward to seeing you at another webinar. Thanks so much.